You're live now, thanks, Chair.
Okay, thank you. Can I welcome you to the meeting of the Health Scrutiny Panel. Can we remind all participants that the normal rules and procedures apply? For example, comments and questions need to be directed through the chair. As we're meeting virtually, proceedings may take slightly longer, so your patience is appreciated. As per our virtual proceedings, if questions have been received prior to, I will call to that relevant member. If you're invited to speak, please state your name and be as specific as possible about the issues. While members of the public can view this meeting via YouTube Live, they will not be able to actively participate or comment. As it's being live streamed, can I remind all participants that the conduct should reflect this? Right, do we have any apologies for absence?
Yes, Chair, we have apologies from Councillor Bell and Halawi, with Councillor Cook acting as a substitute for Councillor Halawi.
Okay, thank you. Minutes of the last meeting, which was held on the 11th of January. Are we happy? Do we have a respect that it was a true and correct record? Tom,
move them, Chair.
Thank you. A seconder. Yeah.
Oh, hello.
Thank you.
Oh.
Okay. Everyone in favour of that? Great. Right. We have the next item on the agenda, and I'm not quite sure whether participants are here yet. Oh, they are. Yes, I can see. Yes, they are. Excellent. Thank you very much. Item 4 is the prospects surgery update, and we have members of the surgery here. I believe we have Jane Hodgson, who is the practice manager.
In Henderson.
Yeah, and we have 2 other members of the surgery. So we'll be delighted to hear from you. We also have members from the CCG as well here as well. So if you would like to give us an update, we will be happy to hear that.
Chair, if I can commence and just provide you in terms of where things are from a CCG perspective and a commissioning perspective. So
okay, thank you.
As committee members will be aware, we provided an update in October where the CQC report had been published and the findings, and we described alongside of the practice the actions that were being undertaken. Following that, obviously we received the request to provide a further update in 3 months to the committee to ensure that those actions were being progressed. As I explained at the last committee, the CCG is the Commissioner for Contract of GP Services, not the regulator. The regulator is CQC, and it will be the regulator who will determine the findings of any evidence that's provided to CQC to ensure that actions are being undertaken. So members are aware of the areas rated inadequate as previously presented and the 2 breaches that were placed upon the practice at that time. Since the last meeting, the CCG, NHS England, the practice and other stakeholders have met to make sure that the practice are undertaking a range of actions and ongoing actions to make sure that they're able to remedy the situation that they found themselves in when the CQC regulator went out and determined their findings. The practice have subsequently and since the last meeting provided additional evidence to CQC within all deadlines that were required, so they have been compliant with the regulator's requirements. They have been further inspected by CQC since the last meeting that we held with yourselves, but they have not been rated. And that was a review that was undertaken by CQC. It was an announced review of the practice on the 18th of November. And we've provided you with the links to the report that was subsequently published following that review. It hasn't been rated and it won't be rated until CQC undertake a further review within the 6 months since the previous findings and reports. So in essence, 6 months from September, the practice within that period will be revisited and re-rated. So CQC, when they announced the review and they undertook that, they found that the majority of risks that had been identified in relation to the breaches had been addressed. However, there were a few areas that were still outstanding. And as outlined in the report, and I'm sure the practice can provide you further information in relation to the work that they've been undertaking. They're still in special measures as a practice, and that is consistent in terms of the CQC action that's being taken. And as I say, they'll be inspected again within the 6 months. So we will continue as a CCJ. And other stakeholders have been supporting, as I say, the local medical committee have been supporting the practice, the federations and the primary care network, alongside of the hard work that the practice has undertaken to date to try and remedy some of the situations. So that's just to provide you with a bit of an update in terms of where we are from the last meeting, to reassure you in relation to the work that's been undertaken with multiple stakeholders to make sure that the impact isn't being felt from a patient perspective, which is really important. And I'm sure I'll hand over to the practice and they'll be able to provide you with an overview of the actions that they've taken since the last meeting. Thank you, Chair.
Thank you. Okay, would you like to go ahead?
Hello, good afternoon. I'm Dr. Sabir. I'm the senior partner at Prospect Surgery. So thank you very much for giving a brief to the council. So what we've done really over the past few months now, since we had the last report, we have worked quite hard. We brought about some changes in terms of the working practices, developing policies, and looking at systems as such, so that whatever we achieve, it is sustainable over a long period of time. That's where we have concentrated mainly upon. And we also recruited a new staff, which included a pharmacist and a locum nurse to help us improve on the number of cervical smears, which we were down on before. So in terms of the number of issues that they were raised, the main issues they were raised about the safety of the high-risk drug prescribing. We addressed all that, and we established system, and we do a regular monthly audit on those things. And when CQC inspected us, they found that all the outstanding bloods or the risk assessments were done on all the areas. There was one small area, which is the chronic kidney disease, at which we think it was mainly a systemic thing rather than the actual problem. But that systemic thing also has been addressed, and we don't think that remains a concern anymore. And when the CQC will inspect, we do think that that will be totally addressed. In terms of our cervical smears, we have improved from a figure of 49%, which was at the time of the last inspection. And that was an aggregate figure between the two groups of the patients that do. If we work out an average now, we nearly reached a 70% figure now. So that's a big improvement. The big improvement has come about by an additional staff from outside. In addition, our own nurse has completed the training, who is now doing the cervical smear on a regular basis. So, and we also have changed the system, the way we invite people. So we're being very proactive. We're calling people and trying to make sure, and we have recognized the areas where in a traditional system of sending a letter in our practice, it just cannot work. The reason for that is we got so many patients who are in a younger age group, and they are also students. Some of them don't even have an idea about the cervical smear. So it requires a lot of kind of coaching even before bringing them into the practice. So we are effectively now calling the patient. The doctors are calling them also when necessary, and the nurses are. So working as a team, everybody is making an effort, and the results are shown that there is a great deal of improvement on that area. We also have addressed some of the issues about, for example, asthma. The patients were being prescribed a large number of inhalers, especially one particular inhaler, and we brought a system around now, so even by error, it is less likely that somebody will get the prescription for an inhaler, and everybody gets to speak to the doctor before that inhaler is issued. So we believe that that is well under control, and in fact, on that, we can see on our QAF figures that we have never been so high in our figures historically in terms of doing the asthma reviews, because we work so hard on it, really, ourselves, as well as our nurses now fully trained to do the asthma reviews, as well as the COPD. So in terms of resources that within the practice, there's a lot of change now. We got nurses who previously were not trained. As you know, we mentioned at the last meeting, our nurses, they were originally district nurses, and there were areas they needed to train in. Now they have completed their training, and they're functioning to their full capacity and their full knowledge, and that has helped us to drive forward with the reviews that a patient required. Okay, and also, as I say, we have established the systems where we are carrying the regular audits. We are also concentrating on dealing with the issue of gabapentinoids, which is gabapentin, pregabalin. And although we are in an area where there is difficulty because of the deprivation that we are in, there is a high rate of gabapentin and pregabalin prescriptions. However, we have appointed our pharmacist to work with the patients and work in a programmed manner to get the patients wherever it is possible. And it has worked. We've done audits, and that has shown a great deal of improvement in that area too. There is also issue in childhood vaccination, which we are again, as I said, we looked at our system again, and again, this is more like a proactive system now. People are being given an appointment before they go out, and that has improved our vaccination rates also, and we'll continue to work on that. In terms of the child safeguarding, we have established a communication with the other teams. We regularly, one of our GPs, the child protection lead, attends the MDD meetings. The staff are fully trained, and everybody now know in terms of their roles of any significant events within the practice. They know how to do them. They know how to approach and how to discuss. And the whole team in the practice, including the nurses, as well as the staff, they are involved in these meetings, and we are holding the meetings quite regularly now. So our practice meeting, business meeting, is held once every 2 weeks. In addition, we've got a clinical meeting, which is on alternate weeks. And there is a staff meeting, which is for the practice staff. And there is a participation from manager as well as the doctors in that area so that we can address all the concern from the staff. So, is there anything? So that's all we have to say. We're open for questions if there's anybody who wants to know anything more specific about. Having said that, at the end of it, I think we are continuing to work on it. We feel that in terms of addressing the concerns, we have done so. We are in a maintenance phase where we're looking at things that they continue to work as we have worked them out, and just to maintain everything in the way. And if that's what we are able to achieve, we don't think there'll be any concern from CQC at their next visit.
Okay, thank you for that very comprehensive update. Do we have any questions? Councillor Cook, I see you've got a question.
Thank you, Chair. It worries me when I know drug names. So pregabalin and gabapentin, I know those because those have a street value. And I'd be sort of more concerned that those were prescribed in inhalers, if I'm honest. Can you tell us sort of like in a metric, how many fewer prescriptions are being given out for those, or how many people are now not using those medications since the sort of initial assessment? Yeah,
okay. So we'll have to open the audit. We have carried out an audit. And as I say, this is a work that is ongoing on gabapentins and pregabalins. And this is a difficult area. You are right. There is a street value. We do agree, and everybody seems to know about this very well. And the good thing about that is now, we mentioned last time also, there is a change in NICE guidelines. So it actually has allowed us mainly to avoid starting the prescription, because now we can refer to the guidelines and we can talk to the patients, say, well, look, this is not helpful for you to have this medication, and this is shown by research. So that's one tool. Initiation is one of the things where we're not making that initiation. We're taking alternative routes to prescription for management of pain, for example. Yeah. Second is, obviously, we have, as I mentioned, appointed the pharmacist who is actively looking, and she is engaging with the patients, and she is discussing with them, and in a programmed way, because it's not possible to bring somebody off if they're actually taking it. If they're selling, that's a different matter. But if somebody's taking it, then obviously you need to do it in a programmed manner that you can't take them off very quickly. So this is what we are doing, and there is we just practice manager just gone out to get the okay. In terms of the, I'll come to the inhalers. Obviously, nobody is now being prescribed more than 3 inhalers if they have got a diagnosis of asthma in a year. So there is a mechanism that if somebody was to get a second inhaler, or they request a second inhaler, it cannot be authorized without first talking to doctors. Before, it was possible for patients to get it on the repeat prescription. So what we've done is the mechanism has changed. So now the prescription is put on as what we call as an irregular prescription, and there's a maximum limit on that. So they can only order 3 in a year. They cannot order any more than that. Any time they go to second, they have to speak to the doctor. And this is the way it's working. So all the patients total, all across the board, where they have asthma, their number have been restricted. And that is evidence-based. This is how it is. So the number is not going to increase. That is helping. So, okay. So in terms of our pregabalin prescriptions, for example, in Q1, the prescriptions were 147 for pregabalin. Okay. And then in Q2, which is July to September, the prescriptions went down from 147 to 132. Q3, which is between October and December, the prescription number have gone down to 117. So this is pregabalin. Second one, which we did for gabapentin, which was in Q1, 66, Q2, 56, and in Q3, which is the last quarter, is 48. Okay, so this is overall, the number is 213 total, and then in the second quarter, 188, and in the last quarter, 165. So this is the combined figure of the gabapentinoids, which includes pregabalin and gabapentin. Is that okay?
Yep. Yeah, that's a considerable drop, which is good because I've seen people who have been on those, and there's a behavioural change which is quite worrying. So I think I accept that there's genuine people who need it, but it is nice to see that there is a drop, because it does cause sort of those effects. Thank you.
Okay, thank you. Councillor Morstan, you have a question.
Thank you, Chair. I don't know whether Karen Hawkins or the doctor can answer this. Is there a program of inspection of GP surgeries, a regular inspection? Thank you.
So yeah, we get regular inspections from CQC, and then they rate the practices according to their inspection and what they find. We had the previous rating of good when we had the last inspection before the last, when we rated that we required improvement, and which is where we are at the moment. So obviously there will be another inspection which will be rating us, but that will be a full inspection. The last inspection that we had in November, it was mainly to address the areas of risk that was raised in the inspection before. So we are expecting an inspection soon, and that will be the one that will rate us. Once you achieve a good rating, then they do what I understand is monitoring, remote monitoring of the practices by looking at their figures and data. If everything is okay, then they don't get inspected for either 3 years or 5 years. So this is a decision taken by CQC on the basis of what they find on the facts and figures they are available to them.
Thank you, Dr. Karen.
Yeah, I can also pick that up, Councillor Marston. So CQC, they've changed the framework of inspection recently. So that's now been updated. So what they do is they monitor practices on an annual basis, and they do that through what's called CQC Insight. So they are the regulators, so they're the ones that will go out and formally inspect practices. And what they do is they look at the data across all GP practices, so not just prospect, they look at it across the board, across every practice that's commissioned. And then they look at the relative performance for the majority of the indicators that they're using, and then they look at whether it's significantly variant from an average. And then when they look at that evidence, they would then look at with the practice, if they've got the information, they then look at information from stakeholders. So they normally engage with Health Watch, they'll engage with ourselves, they'll look at the information that patients may have provided directly to CQC. And if the review, if that collection of information identifies that any quality of care might have either improved or deteriorated since the last rating, that's when they might decide to inspect. And then they work with the provider. So if they decide to inspect, they normally give a call to the practices under their annual regulatory review, and they would ask them a set of questions, and they would use the data to help inform some of that as well. And then they would look at the rating, and they may go out and inspect the practice at that point if they had any concerns, or if they wanted to look also, because sometimes they do like to look at best practice and share that best practice. And then they will continue to inspect within 6 months, as we've advised for Prospecta after their rating, because they were inadequate, and then within 12 months anybody that might require improvement, so they can be rated as inadequate or requires improvement or good or excellent. And that's how CQC work now, and they normally provide a pre-inspection information request to the practice before they would undertake an inspection as well. It's a very much risk-based assessed approach that they undertake now as the regulators. We do work closely with the regulators and with the practices as well, and look at assurance of our primary care providers as well.
Thank you, Karen. Thanks, Chair.
Okay, happy with that. Any other questions? Councillor Arundel, you have a question.
Thank you, Chair. Yeah, the question of the doctors. Would you agree that the changes you've made have been beneficial to both yourselves and your patients?
Indeed, they are. Yes, of course. I mean, I think we mentioned this last time. Sometimes you carry on things and you kind of, in your day-to-day practice, you think you're doing the right thing. It gave us an opportunity to reflect and look at our systems and processes, and it allowed us to strengthen it. And obviously, there were a lot of new staff, and it gave us an opportunity to give them a training at the same time. And I think it has been beneficial both for us as well as for the patients, and we would like to be able to maintain it in this way and continue to benefit both of us, patients and the staff.
Right, thank you.
Thank you. Councillor Rooney.
Thanks, Chair. Yeah, I was present at the last presentation that you came to, Dr. Sadea, and I am really heartened with the work that's gone on, because I think at that point we were very concerned about the surgery and how the practices had slipped, and it looks like you've done a tremendous amount of work. So I'd like to commend you on that and look forward to seeing that progress. Councillor Story has put a question in the chat, if I can just go to it. She said, this will be for the inspectors, has COVID impacted on these inspections? I can just raise that as well, but thank you for coming along today.
Okay, so I mean, previously when we had the inspection at that time, a lot of the things we did mention, the COVID did have some influence on it, on the patients. For example, the patients were refusing to come in for the high-risk drug monitoring. But obviously, equally now, people's concerns are a little bit less now. Since the lockdown disappeared, we were able to kind of contact the people and encourage them to come in. There is still some influence, but we are now trying to actually work out even the ways how to tackle these. So I think in a way we have learned to work in these difficult circumstances and still be able to achieve the targets where we needed to.
Okay, thank you. Any other questions? Don't see any hands raised. Can I thank you very much for a very comprehensive report. I think from what you've told us, you really have got on top of this, and I wish you all the luck in the future, because you've certainly put a lot of hard efforts into that. For the report you gave us today, I did note about the asthma, having been on that myself many years ago, and the various other things you do, and of course the staff team, which is the team meetings, which are very, very important to getting the staff involved as well as the clinical side involved. So I think that's an excellent report you've given us. Any other questions or any other input from anybody else? From Karen? Are you happy with that? No, okay. If there's no other questions, thank you very much for attending. It is greatly appreciated, and I'm sure that the next time you come to see us, things will be absolutely spot on. Thank you.
Thank you to all. Thank you.
Thank you.
Excellent. Bye-bye.
Okay, bye-bye. Okay. The next item we have is health inequalities, and we have Karen Smith and Graham Nicholson. Graham, you're glutton for punishment. You came and gave us a report last time at the last minute, so we look forward to that. Karen, are you going to lead on this?
Good afternoon all. Hello. Yes, my name's Karen Smith. I'm Head of Achievement for Middlesbrough Local Authority, and Graham and I are here today to discuss with you the impact of health and education inequalities and actions that we're taking to secure improvement and to ensure that children in Middlesbrough have the best life chances possible. And of course, we do await with bated breath around the white paper levelling up document that is in circulation at the moment, with the announcement of £5 million into education for 55 areas, disadvantaged areas, of which Middlesbrough is one of those. What we know from the white paper to date is that the aim is to offer retention for the best quality teachers, maths, physics, computing, and the other sciences, so that we are retaining the best quality teachers. What it also means is for any school sitting on a recurring requires improvement judgment from Ofsted, that they will be encouraged to join a multi-academy trust. What we know from a Middlesbrough perspective is that all of our schools who were sitting on an RI judgment are now part of larger multi-academy trusts, so we might not see any impact here. But as we move into the presentation, I just wanted to give you a bit of an oversight there into the white paper that is being circulated. Scott, do you have the presentation?
I can do, yeah. If you give me a second, Karen, I'll just throw it on the screen.
Thank you. So whilst that's loading up, the Achievement Service is another word for education in terms of outcomes and supporting school improvement for schools in Middlesbrough and settings. We have 54 schools, 70 nurseries and 42 childminders, of which my team are responsible for ensuring professional development and children and young people are afforded the best start in life chances. As we work through the presentation, you will see that there is much overlap within the health services. In fact, collaborations are improving as we speak, and you'll see that through the strength of the presentation. In the learning and education strategy, our mantra is to ensure that every child and young person in Middlesbrough has equal access to high quality education that increases and improves life chances through the achievement of the best possible outcomes at every stage of their learning journey and beyond. This can only be achieved through partnership working, and I must stress that collaborations with our schools and our stakeholders, including health practitioners, have really come to the fore as we emerge from the pandemic. And I think that the foundations that have been built and developed will just grow from strength to strength. Next slide, thank you. So in December, the Best to Start pathway was launched, and this was to afford vulnerable families and pregnant mums the best 1001 days in life. We recognise that this is a significant period in human development, and it's a dramatic transformation which is facilitated by a highly malleable brain that rapidly measures rapidly measures the result of neurological disorders. So the Best Start pathway has been created jointly with the Harrogate and District Foundation Trust colleagues, and the programme begins to to recognise that the antenatal period and the contact with midwifery are key to the developmental and neurological development of a baby whilst in the womb and pre-birth. In recognition of the significant vulnerability of families across Middlesbrough, the Best Start pathway was introduced and the threshold criteria are as seen to help those vulnerable adults throughout their early stages of pregnancy and into birth. The school readiness team supports a lot of this development and delivers interventions to vulnerable families to ensure that they are giving themselves the best start and the best opportunities for their children as they progress through into the early years. The school readiness team work interactively with families, and throughout the pandemic we've adopted a very successful virtual offer, which is in turn given us vulnerable oversight of our vulnerable families, and we will continue to work in this fashion as well as reopening the children's centres as we begin to emerge into life post-COVID. So as you can see, there are a wide range of threshold criteria that help us identify those mums and those families who would benefit from the first 1001 day support set out on the Best Start pathway. Next slide, thanks, Scott. As I've alluded to, there are a range of other initiatives that the school readiness team deliver on, and the Healthy Eating and Nutrition for Really Young Children and Fussy Eaters programme, as it's affectionately known, help support families to address and tackle successfully those issues that any toddler will bring to a family situation. This is really focusing on that nutrition and lifestyle choices are significant to those first 1001 days and beyond preschool for children. The programme really teaches an interactive and face-to-face offer where families can work together through the intensive support of our practitioners around making sure that there is a healthy eating programme and healthy eating initiatives, making the right choices within the family home. Obviously, during COVID, this team have operated a virtual programme, and again, the engagement and participation of families has been absolutely phenomenal, and we will continue this virtual offer as we emerge. Set in a 4-week block cluster, families and health practitioners work together to use a wide range of opportunities to discuss what healthy eating looks like, to address similar problems within families, to almost provide that reassuring ear to other families so that we can all address similar problems that we probably all encounter with our own children around getting those fussy eaters to eat, and to make sure that mums and dads and parents and whoever's at home are making the right choices. Next slide, thank you. So as we look into Play Learning Together, another initiative where families are encouraged to come into the children's centres to learn how to interact effectively by even from bump to birth through talking and singing, asking relevant questions, walking around the supermarket and engaging with their children in a positive way. Through the ages and stages questionnaires, we know the health visiting teams assess the ability of the individual, that the school readiness team then go on to build on this and develop a programme of support based on a one-to-one basis. So there's some statistical figures there. In 2021, during the pandemic, we had 136 families engage in this programme. And of those, anecdotally, we have 94% of families reported an increase in their confidence to interact successfully with their child. 100% have reported increased ability in their early years education for their child. So that is around mark making, verbalising, social, emotional, mental health skills in terms of their interactions and willingness to engage with children like peers and taking instruction, turn taking, listening, and verbalising communication. 82% of children, of families, also report an increase in the ages and stages questionnaire ability. In Middlesbrough, we do see children receive a positive score at ASQs, ages and stages, but what we're not seeing is this always translate into a good level of development by the end of the early years foundation stage in school. So the team is working very proactively and reactively to help assist and look at ways of transition from nursery into school to develop this so that there is a protracted continuum of progress of learning for preschool children. In addition to the play and learning together, and through the shared aim of improving children's speech and language and communication that is explored through the play and learn together intervention, we offer a 2-year developmental review. And so through a collaborative approach, we've refocused the content of the play and learn together intervention so that it is speech heavy, language rich, and communicative effectiveness. We have developed an emphasis on how everyday activities can easily be turned into speech, language, and communication development tools for parents. We have tweaked the delivery model to use more of a coaching style approach with parents so that the focus is on empowering parents and carers to share those practical tips, share best practice, learn from one another, and develop techniques that they are more able to support their child's development at home. We've incorporated the new additional early language identification measures assessment tools used by health colleagues in the referral process, and we've tightened the eligibility criteria to better enable us to show the impact of our interventions with our families. We've devised a new referral pathway, which is the delay in the point at which health colleagues refer to the speech and language therapy teams, otherwise known as SALT, for those services with additional support. And what I'm about to show you on the next few slides is a resource. Thank you, Scott. Sorry, I've jumped ahead of myself. Could you please go on to the next few slides and we'll come back to these. So the support, that's it, the support to talk. So we've developed this resource of recognition that typically pupils and children in Middlesbrough have very poor speech, language and communication skills. The programme has been developed without any funding, and it's purely been led by passion, commitment and a vision to ensure that children, young children and their families can develop support to talk initiatives in their own home. We did submit a bid in 2018, of which Graham and health colleagues were part of, to the DFE to secure funding to roll out a speech and language pathway, which at the time was called South Tees Talks. That bid was unsuccessful, but because of our determination and our understanding of the needs of young children in Middlesbrough, we set about creating the pathway regardless. It was launched in January of this year and is a self-help tool for parents and practitioners to work through a range of strategies that include ethnic minority support, include special educational needs support for parents, so that parents can identify following the pathway by following the resource materials before any referral to health teams is made. This isn't to decry the fact that a health referral might eventually be needed, but what we're trying to do is educate parents and practitioners to follow a range of process and steps through the resource before that referral is made. We know that through the pandemic, there are a series of year groups, particularly children and babies born during the pandemic, who are delayed in their learning. So this is a fantastic tool that has now been shared across Middlesbrough and into Redcar and Cleveland with health colleagues, with schools, with social care teams, that we can all help promote speech and language and communication through the Support to Talk resource. Next slide, thank you, Scott. So this is the Support to Talk, and this is a snapshot from our website, which is the website address there, and it's the Learning Middlesbrough website. This is the one-stop shop, as we call it, for professionals and parents to access, and the wider community, sorry, to access resource materials that might help children learn at home. There's a lot of remote learning going on there, but the Support to Talk materials that I've just been describing sits on here also. There is a parent and professional page. There are support to talk examples and activities and encouraging tips and tools that parents can use at home. And as I said, this extends into families with English as additional language to support. Scott, sorry to be a pain. Can we now go back to the AL slides? Thank you. So in addition to the school readiness team, we also have an ethnic minority achievement team within the education directorate within my team. And this is called the Emac team, which you might have heard of. The Emac team work with families who are international new arrivals to Middlesbrough and support children with English as additional language in schools through our TA offer. Through the International New Arrivals Protocol, the team works steadfastly to encourage families who have arrived in Middlesbrough and integrate them positively, to familiarise themselves with the local area, to signpost schools, to help families complete admission forms. And this is all done through a process of parental interviews, a series of workshops, a series of familiarisation activities. And we also undertake safeguarding and SEND activities, working collaboratively with the SEND team. This brings me to the SEND protocol. For those pupils and children who are of school age, we have and who arrive with complex needs into Middlesbrough and who are international new arrivals, a pathway has been developed to support the engagement with health practitioners to help work with the families to ensure that the right educational placement is identified for the pupil to then fully access their full education entitlement. More recently, we've developed great working opportunities within the SEND and social care teams to ensure that there is a holistic and joined up thinking to ensure that the best value and the best educational place is offered the pupils. We know that many schools have their own AAL teams, and that's absolutely fantastic. But what the team can also do is work with families to support their understanding of the education system in Middlesbrough. So, for example, we have lots of families from Romania. We're seeing an increase in families coming from Nigeria who are studying in the university, who don't understand the educational system in terms of arriving for school for 9:15, for example, the need to perhaps own a uniform and how best to secure that uniform. So the team are working very creatively to remove any barriers to learning in the first instance. Thank you, Scott. In 2017 to 20, the team received funding from the Controlling Migration government funding that helped address and close any literacy gaps as a form of closing any disadvantaged gaps for vulnerable families, AEL pupils and international new arrivals. The programme has since closed. However, we are maintaining those set of standards and principles in Middlesbrough, and despite not having any funding, the CMF project is moving into a phase 2 Middlesbrough approach. This will support families in that familiarisation to become aware of the geographical surroundings, to be able to navigate systems, to know where to access appropriate support, and to be able to help their families and children really integrate themselves into the British way of life, and particularly Middlesbrough. Throughout COVID, the team have been diversifying and supporting social care teams and health teams to have that vulnerable oversight so that we are assured the safeguarding measures are in place for vulnerable pupils. They've taken food parcels, delivered leaflets, delivered books that we've secured through the National Literacy Trust to engage and continue remote learning, so that during periods of lockdown, families continue to be supported. I think there's a very whistle-stop tour. Thank you, Scott. I think that's the end of the presentation from the achievement team.
Thanks. Yeah. Just moving on to myself, really. I just wanted to really set the scene. I've got part of a presentation to share. I'll just quickly share my screen there, just to move on from that.
If there's any questions, we'll take them at the end, if that's okay.
Yeah, great. Thanks, Karen. Everyone say that okay there?
Yeah, that's
Yes,
great.
yes.
Thanks.
Sorry, I can't see from that. I can't see if there's any hands up in the background there.
That's
So
fine.
great, thanks. So really, today I just want to set the scene with some of it. Really, I think it's important to sort of acknowledge really that we know that in Middlesbrough we've got a lot of challenges. You know, life expectancy. I think obviously the board will be the scrutiny board will be well versed on this, but life expectancy challenges, you know, in the local area, health inequalities, and you know that plays out. That we have a really big inequality gap in terms of our most least deprived wards. As you can see there, you know, if you're born in Central Ward in Middlesbrough, we know you're going to live, you know, you're going to live a lot less than you would someone born in Martin East, particularly if you're a male. But I think one of the things we often forget that where this starts from birth, and you know, Karen's talked, you know, in great detail there. I think about some of the great work going on in her team and the great great work going on prior to school and in school. But I think it's important to acknowledge, I think the work that's going on a lot of the time, we do need to concentrate a lot of the work in the first 2 years of a child's life, because it's some of the most important. I've got a little video in there which I'll leave for the time being, and you can pick up and have a look at when I circulate the slides. But really, the first 1,001 days, they're just really a unique period of growth, and most of our sort of connections in the brain are formed during the first 2 years. So the basic brain architecture is shaped, and the development of the child's brains really it provides a future for all the, you know, future learning, behaviour, and health. So it's so important, and it's one of the reasons I think why public health, you know, place a lot of emphasis and have been doing a lot of work in this area, that we continue to support our parents have in the first 1,001 days to get the child off to the best start. Because if we don't, we know they're not going to be on an equal footing by the time they get to 4 or 5 year old in school. So when we talk about inequalities in school, you know, they start well before school, really, is the message sort of I'm giving off today in terms of that. As you can see there, and I think Karen's touched upon some of it before, just a quick graph there, which I think, you know, tells a real story there about the brain's ability to change in response to experience and the amount of change it's required. And as you can see there, when you're really young at 2 years old, you know, in birth, you can really flex and change in response to experiences, and your brain continues to grow and experience a lot. Or when you get old, and like me, it takes a lot of change to respond to experiences. So it's just vitally important, really, that in our first years of life, we support the children and continue to support them all the way through, you know. So again, in terms of being school ready, and in terms of addressing health inequalities in school, I think it's important not just to talk about, you know, attainment there, and I just picked that up in terms of building blocks around being school ready. You can see, you know, in terms of a child's development and getting into school, speaking and literacy, which Karen's touched upon quite a lot there, you know, routine, self-care, fussy eating, as Karen's touched upon there. It's such a multifaceted, you know, area, and it requires a whole host of things for a parent to do, and you know, people who provide care to children to do, to make sure that they get off to the right start and flourish in school. So really, in terms of public health and health inequalities, what we're doing really, I've put it into 2 areas just to give you a bit of an overview. Is in the first 1,001 days, and really school and beyond. So we do a lot of work in the first 1,001 days, and really our sort of our core public health sort of delivery arm, which works frontline with supporting parents, is around the Healthy Child programme. And you know, they do a lot of ages and stages questionnaire. They have 5 mandated contacts, you know, in the first 2.5 years of a child's life. And what they'll really pick up is things such as speech and language difficulties, which are key for, you know, for education, but other things, you know, where there'll be early triage and support into specialist health services. So, you know, it's vitally important, really, that children are supported through all of their life. But in the first few years, picking up, you know, health needs and understanding health needs is vitally important, because, you know, it supports the family in terms of access to health services, but more importantly, if children are supported with their health needs, they'll stay in school longer as well. So the Healthy Child programme does a whole range of things, really, ranging from, you know, early assessment and referral into speech and language services, assessment and referral, you know, around audiology, many things that are important for a child's life in school, particularly our most disadvantaged, where we know they've got more profound health needs. So in terms of development and commissioning around targeted public health interventions, we've done a lot over the years. You can see there, I've just mentioned a couple really: smoking programs, Best Start pathway, breastfeeding boroughs. All of these have real bearing impact if you think wider about the journey of a child into school and the attainment they'll have. We know that the Best Start pathway has just been developed. It's starting to be developed and delivered in collaboration with the Healthy Child Programme and some of Karen's team in the School Readiness Service. And really the whole ethos behind the Best Start pathway is to give the child the best start in life and enhanced support. Some of that through speech and language support, some of that through preventative support that will keep the child safe, which is delivered through the Healthy Child Programme, access to things that'll keep them safe and safe from child injury, things such as home assessment environment tools. And all of this plays a real part in making sure the child's got a real strong, home environment and home learning environment to make sure that they're flourishing later in school. Likewise, sort of things such as smoking programs. We've invested a lot of time and effort in smoking at time and delivery and smoking in pregnancy work over the last sort of 10 years now. I think our smoking at time and delivery rates were some of the worst in the country, and about 1 in 3 smoked about sort of 8 to 10 years ago. 1 in 3 parents smoked who gave birth. We're at about 1 in 5 now. And if you think about the knock-on impact of that in terms of, it's the biggest cause of infant mortality, but more importantly, when we're talking around health inequalities in school, asthma in children, breathing difficulties. By doing these stop smoking programs, the wider impacts are that children stay in school, they get better support in school, the educational attainment's better. So there's wider impacts, in terms of on the child than just sort of educational attainment. The whole gamut really of health and social support does really play a part in keeping children in school, making sure they have better educational attainment, and making sure that they flourish and enjoy school. And really just the South Tees Best Start in Life programme is the last thing I wanted to come on to today. And that's a wider piece of work we've been doing, and we've just started really on our journey around some of that, around the first 1,001 days. And I think what we're trying to do around that is create really a whole Best Start in Life system in the first 1,001 days. I think we know that services in the first 1,001 days, due to a lot of the challenges, are quite, service-centric sometimes and really operate within their own sphere. And I think some of the work around that is to try and, improve multi-agency working and really develop, a common understanding around the workforce and then those that commission the workforce as well. So a lot going on really in the first 1,001 days. And in school and beyond, we've got sort of a lot of work going on, and we know, I think, that some of our biggest needs in school are around, mental and emotional well-being. I think it's well publicised nationally, but we've got the Head Start programme, which I'm sure a lot of you will be familiar with, which is based around really emotional resilience in schools, and it's a real, it's a real trailblazing project and program, and it's really at the forefront of a lot of the work that schools are doing around making children more emotionally resilient, being able to deal with problems in school, being able to deal with their emotions and making them more resilient, so again they stay in school and flourish in school. And I really just want to touch upon some of the last couple of things really, which are sort of pertinent to what's going on at the moment really with what has gone on over the last couple of years with COVID. Myself, and I know Karen's been heavily involved in some of this as well, particularly over the last couple of years, COVID advice and support to schools. The public health teams provide a lot of advice and support around COVID outbreaks to schools, and that in turn has been really vitally important, I think, in keeping children in school. And we know it's been well publicised in the press, the importance of keeping our most vulnerable children in school and making sure that that they get access to really high quality education, so that their presence, so that when they don't miss school, it doesn't cause problems and increase health inequalities in later life. So that's been a real mainstay of the work that certainly the Public Health Service have done, the children's side of things, over the last couple of years now. And just finally there, in terms of sort of school and beyond, is just education and healthcare plans. And we don't per se sort of deliver on that, but I think it's really important when we talk about on the SEND agenda, and you know, there's a review care assessments team there that deliver that, but it's a real public health, you know, agenda where the education healthcare plans are reviewed, and the support that you know, our vulnerable children get is reviewed. So that's really the end of my sort of presentation today. Just to move on, really, if there's any questions from me and Karen, really, from the board.
Thank you, Graham and Karen. Very comprehensive presentation there. Quite a lot of facts and figures to take in. Do you have any questions? I can't see any people at the moment. We have Councillor Cook again. Councillor Cook?
Yes, thank you, Chair. So, yeah, I'm really impressed. Yeah, so there's only one really question that I have. There's been some research done locally around parents who are neurodiverse and their experiences trying to support their children. And it's really interesting to sort of look at the feedback that the parents have given around their sort of needs with their child's needs as well. So like sort of paperwork not being friendly to them, and like sort of other barriers that they've got. But I noticed that it wasn't actually a best start pathway for if a parent, I don't know how you'd sort of identify it unless they had an SEN sort of marker previously, but that in a way would be quite a good. The research is really interesting, actually. I'll try and pass it on once I've come off this.
I can just offer a comment to that. I know the neurological pathway team have undertaken a parental survey and questionnaire to determine, you know, as you say, the level of paperwork and their understanding of its completion to try and ease the burden of having to complete that in the first instance. But in terms of the best start pathway, I can't. One of the threshold measures. Graham could offer an explanation to that.
It's not one of the threshold measures per se, but I would expect the nature of the thresholds that are in there, the 10 eligibility criteria, it would be picked up under there anyway, because they would probably have an underlying issue of one of the other things. There is a marker in there as well, councillor, around professional judgment as well. So what we have in there is that the professionals are allowed to obviously look at their own judgment there if they feel that a family needs additional support. So generally we feel that the pathway eligibility criteria is quite robust in that respect, because we've got a lot of skilled professionals in both Karen's team and the health visiting team undertaking these assessments. So generally the families will be picked up. It'd be interesting to bring some feedback at some point in time about the best start pathway over, because it's really in its infancy at the moment, and we think it'll have really big benefits to some of our families in Middlesbrough.
Okay, thank you.
Yeah.
Okay, thank you. Then Councillor Story, followed by Councillor Morstan.
Hi, sorry, my voice is really croaky. Can you tell me something about the breastfeeding boroughs, please? Because I haven't heard that before, and I'm on the South Tees maternity voices, and it hasn't been raised on there either.
All right, okay. So breastfeeding boroughs, really, it's in its infancy, but it's born out of the it's really born about tackling social norms. I think we know that you probably know from the social, from the Maternity Voices Partnership, but you know, we have a bottle feeding culture in South Tees, and it's about really the whole breastfeeding boroughs thing is about tackling social norms, and it's a new piece of work that's ongoing. Really, it'll entwine a bit of are you familiar with the breastfeeding welcome scheme? It'll pick up a lot of the work around the breastfeeding welcome scheme, really looking at developing sort of a campaign to tackle social norms and really making breastfeeding more visible in the area, which is really well needed, I think. Is that okay? Great.
Okay, thank you. Councillor Morstan.
Yes, thank you, Chair. Karen, your excuse me, your slide, Emac Education Directorate, you referred to CMF projects and the funding ended in 2020. Congratulations on continuing the programme, but is there any possibility of future funding arriving for this? The funding stopped, but the project didn't, which is quite typical of a lot of things, I think. But and it's not something that once the funding stops, you stop.
No, that's right, Councillor. We the team, I'm very fortunate to lead such a passionate and creative team, and the lessons that we learned through the CMF project and its delivery, we've managed to continue. We're still wanting to provide English classes for adults, and we're working very closely with Claire Kemp's team in community learning to ensure that we can deliver adult education to our families, in recognition that obviously learning isn't just for children and young people, it's for our adults as well. Around the 1,001 days in educating our parents, it's really key that we educate holistically. So the lessons that we were delivering on the CMF project are continuing, and I'm pleased to say that despite the lack of funding, we're managing to continue progress, we're managing to continue support systems, we're managing to really work with those families. Obviously, with the relaxation of the COVID rules, we're now beginning to open up the hubs, and we have submitted a family hub bid to the DfE, of which we found out, if we're successful, on March the 17th, to integrate 4 family hubs, which is an old sure start model, typically in its easiest explanation there, to create a north, south, east and west hub model, a hub and spoke model, utilising and repurposing children's centres, so that we have a community where people can come at easy reach, rather than, so we're providing services in localities rather than people having to go out and search for services. And in that family hub, we are also wanting to extend work with international new arrivals, AEL, health, education practitioners, social care teams. So we're actually providing a round picture, but through the CMF, sorry, referring back to your question, is that we are continuing to deliver the delivery method that we employed at the time, so that we can continue to measure the impact of that through our family learning teams.
Thank you very much, Karen. Thanks, Chair.
Okay, Councillor Davison, you have a question.
Yes, my question's for Graham, really. It's with regards to the Head Start programme. How many schools have the Head Start been able to work with? And are they still working with as many schools as possible? Because the schools, there's been a lot of children off the school with COVID. I know that personally, but are they able still to go into all the schools, or is there just certain schools they're able to work with?
Thanks, Councillor Davison. I couldn't give an accurate figure in terms of the number of schools at the moment that Head Start are working with, and the challenges some of them have had. But I can certainly get some information in terms of I can get some further information from Wendy, who leads on the programme, just in terms of what the reach is like at the moment and some of the challenges. We can certainly get some of that.
Thank you very much. I'll be very interested in seeing that. Thank you, Craig.
Yeah, Karen, you have something to add to that?
Yes. So, Councillor Davison, we also have a mental health in schools project that's run across Redcar, Cleveland and Middlesbrough. It's called Inside Out, and what we're doing is working to support 70,000 vulnerable pupils with mental health initiatives to work with schools to deliver on these programmes. We are seeing an increase in mental health, social and emotional needs in schools, and we're also seeing this impacting on behaviour in schools as well. So there is much work going on to address this in the local authorities at the moment. So we might be able to bring the information of the project to you at a future date.
Thank you very much. Thank you, Karen.
Thank you. A couple of things I picked up on there were sort of in the Henry scheme, the fussy eaters. I mean, that's been around for a long time. I remember at school and prior to that, there was a lot of, perhaps including myself, fussy eaters, and it is something that was not touched on in the past. It's not something, if you were a fussy eater, you were thought to be abnormal, when it isn't. It's just that is what you are. And I just wonder what you do to actually help people in that, and to get people to understand, to say, well, they're not eating the food I want, and they say trying to eat the food that we want. So it is something that has been around for a long time, and I'm glad to see it's been brought out to the fore.
Yeah, there's just a little bit of feedback about that program, really, the Henry program itself. A lot of it's based around parenting techniques and role modeling as well, you know, the Henry program. So I think some of the examples some of the practitioners give is that, you know, you can't really discuss and try and get your child to drink water when you're drinking full fat Coke yourself. So those are the types of things that you know, are picked up in some of the training from Henry nationally. It's about role modeling and some of the behaviours that you have as well, and then some of it is around nudge techniques. You know, just getting peas on a child's plate and getting a few bits of things on a child's plate in different textures. So there's a whole raft of things really around the Henry program, how it really impacts on the sort of the families.
We had 102 families complete the programme in 2021. Quite an amazing feat given the ways of working that we've encountered. But I think, as Graham says, is that there is a lot of modelling best practice and teaching parents to be those good role models in the family home. A lot of the work is also built around sort of discipline and you know, instilling sort of that kind of, again, role modeling and expectations in the home that, you know, that need to be exemplified.
I think that's very important, because you have to show to people that, you know, putting, as you say, full fat Coke and perhaps a Big Mac on the table for a young child, they see that as the norm, which, as you say, you should teach people that put peas on the table, you know, the 5 a day with the vegetables. That's not sort of 4 chips and a pea. It's proper food. You know, it needs to be emphasized. So yes, thank you for that. The other thing was, I was interested about the delay in speaking and things due to COVID, etc. That's an important thing that could really knock back the development of a child. So I'm glad to see you developing that. Would you like to say a bit more about that?
The Support to Talk resource is as described, a speech and language self-help tool with a range of resources for parents to use at home, with a range of questions. I think I missed a slide off the presentation, the I can statements of supporting parents to develop techniques to encourage verbalization in home. But also, I think what we've got to recognise through the pandemic is that there is, I won't use the words lost learning, because the learning can't be lost, it just didn't happen. So there is an awful lot of children who are starting into Key Stage 1, for example, who probably haven't benefited from good quality early years education due to remote learning, due to lockdowns, due to provision not being open. So therefore schools are having to really develop, and if you're aware of the education inspection framework, there's a statement in there around intent, and the intent is really asking leaders to identify what, sorry, that's just the dog, to identify where the children need to be, and therefore adapting and re-engaging the curriculum so that there's a lot of work going on through the National Literacy Trust around reading and bringing in, developing a love of books throughout the pandemic. A lot of books have been delivered courtesy of the NLT, but the speech and language pathway is a resource to help before those referrals are made. We recognise that referrals might need to be made, but we also need to take steps to address any inequality in the first instance before that referral is made. Otherwise, our health teams will absolutely be inundated. And it's purely because there is an element of children haven't been taught or responded to in the right way, that they need to engage in that chitter chatter at home, you know, that singing, that bath book bed routine at home. And the Support to Talk resource really takes everything back down to the nitty gritty, the bare bones of how we engage in talking and singing and laughing and playing with children in the home environment.
I think it's certainly, just following on from what Karen was saying there as well, the sort of speech language communication needs is something that doesn't get much attention, but it's something that the partners really well bought into, to be honest. There's quite a lot of work going on, you know, in the health services and, you know, the local authority as well around speech language communication. So there's quite a lot going on around that.
Thank you, because I think that's important. I think over the years it was perhaps was missed a lot in families and things, and it's now been brought to the fore. So I believe that's very important. Any other comments or questions? I don't see any hands raised. If not, can I thank you for your presentation? Quite willing to stay for the rest of the meeting if you wish, or if you've got to go, that's fine. But that really was comprehensive, and I'm certainly learned quite a bit from that. Thank you.
Thank you. Best wishes.
Thanks. Bye.
Thank you. Bye. Next is the COVID update. Mark, what have you got to tell us this time? I see it's going down, but is it going down fast enough? That's the $10 million question.
I think the government's position is it's all over. The crowd's on the pitch,
right.
but I'll give you a little bit more detail than that if I can remember how to do this in WebEx. Hold on. Is that sharing?
Yes, that's sharing. Yep.
Okay.
Thanks.
Okay, so I'll just rattle through this. So if you look at the bottom of this slide, the Tees Valley are, from having been at the top of the tree, are now kind of towards the mid to bottom end of it. So Middlesbrough is 90th nationally as at the 5th of February on 705, and previously had been up around 3,000. So significant reduction there, but still a high rate. And if you look at the daily, the test by day, you can see the massive impact of New Year's Eve, 1,155 tests on that day, and sort of falling, but still, well, that day was one of the first to be below 100 in quite a long time. So we're falling, but quite slowly, which you can see on the rolling 7-day average. The rates rocketed up very quickly, fell quite quickly, and now are sort of plateauing a little bit, and a similar kind of picture in the age bands. So the 20 to 39 were very high, driven by I guess sort of socialising over New Year's Eve and beyond, when the government messaging started to change. The 0 to 19 school age were previously a lot higher, and we're now seeing the more sort of cluster at this kind of rate, but with the over 60s significantly lower rates, thankfully, which is the kind of age distribution of the vaccine uptake. South Tees still have high numbers in with tested positive for COVID, so 136 at the moment. But the critical care is, I guess, the sort of ratio between critical care and inpatient numbers is significantly lower than it was before. So even though we had 176 there, we were still below 10 in critical care, and now is only 2. And I've got some details from a national study on the impact of vaccination on critical care at the end of this presentation. Mortality, still seeing people with COVID on the death certificate. There's a fair bit of discussion nationally that it's a slightly different picture to previous waves with the high rates of infection. There's more with COVID on the death certificate, but isn't necessarily a major part of the mortality. So people dying with rather than of more through Omicron. In terms of the vaccination rates, Middlesbrough's rates are lower than the England average and the North East average, but given the issues with deprivation and relatively high rates of BAME population, relatively good position, I think, for those things that make the vaccination make it a little bit more difficult to increase the rates of vaccination. So just below 77% have had the first dose, which is just a little bit lower than the England average of 79.8%. 70% of everyone have had the second dose, and 51.4% of all people over 12 have had the booster vaccination booster as well. So some issues with the coverage in the population, and the unvaccinated population are more clustered in certain areas, as we'll see with and we've seen previously with the geographical picture. Looking at the age rates, again, this picture of, I guess, where people see a greater potential harm for themselves, the older age groups, much higher uptake than the younger age groups, and the 12 to 15 program in schools was probably the least well developed of all the programs, and we're doing some work across the Tees Valley to try to improve that, because there will be future waves of booster programs as well. And obviously, you can only get the booster if you've had the jab in the first place, so it does give us a different platform in different age groups to move from with the booster program. But that's the picture that we've seen previously. And then looking at the MSOA rates, Ayrsom's a bit odd. It isn't actually Ayrsham Ward. I think it's closer to Central Ward, where the medium super output area is, but sort of clustering around this central area of the unvaccinated, and that's where we've done quite a lot of work with the pop-ups, as you'll see shortly, and obviously the Riverside regional vaccination site is relatively close to that, although I appreciate there are some issues of getting to that if you haven't got a car. These are the pop-up clinics that we've had from the end of January, and the ones that we've got through to the 3rd of March. I'm not quite sure if that's supposed to say the 31st of March or the 3rd of March. Trying to get them as deep into those communities where the rates are low as we possibly can, but we are seeing, as are all other areas, a drop off in the demand for the pop-up clinics. So we've got a paper going to the Health Protection Board on Monday to discuss what the future approach and the ongoing approach to trying to improve our vaccination rates might look like. Just in terms of the vaccination status of hospital admissions, this is a slide from James Cook Hospital, which really kind of just demonstrates how difficult it is to look at vaccination status, because the rates are changing every week of those that are vaccinated or unvaccinated is changing. So they look at admissions or people that have been tested positive in hospital by unvaccinated 1 dose, 2 dose or 3 doses, which is quite difficult to draw any conclusions from, really, because the proportion of unvaccinated that are admitted is quite difficult to see from that graph, because the numbers are constantly changing. So the considering, I guess, a slightly more extreme harm, those that are in intensive care from the Intensive Care National Audit and Research Centre, this is the admissions to critical care by vaccination status by date along the bottom here. So you can see as the vaccination state, as the unvaccinated, those that are unvaccinated decreases in the population across England, Wales and Northern Ireland, those that are unvaccinated and admitted to critical care is a significant proportion of those that are unvaccinated, which is shown more clearly on this graph, which shows by age group that the proportion of those admitted by their vaccination status, basically, if you're unvaccinated, you're much more likely to end up in intensive care than if you've had either 1 dose, 2 doses, or the booster. The booster offers significant more protection than 1 or 2 doses, but I think that's quite a important message in terms of the benefits of vaccination, and we're looking to build some clear comms messages through that to kind of supplement the work that we've already been doing on the benefits of the vaccination program. And I think that's it.
Okay, thanks for that, Mark. They make interesting figures. I noticed that, you know, from the COVID figures, they sort of, as you say, went up New Year's Eve, came rapidly down again. But it's sort of done that before, maybe not on that scale, but I know Omicron is slightly different. As we've now slowing down, which is not a very good thing, they're still talking about, you know, boosters. We still won't have had people with the first and second jab, never mind boosters in the summer or autumn, whenever they decide to do it, because it's not really over. It's just sort of it's come through us like a wave, and hopefully there won't be another wave as bad as that. But how do you feel that people will take things up in the autumn, or is that going to be a major problem for the health department?
I think the uptake of the vaccine and increasing uptake in all of our communities is just going to be an issue that we have to deal with from now until whenever we stop talking about COVID, whenever that happens to be, because as you say, the numbers decrease. You know, those that have had the second jab is a proportion of those that have had the first jab, and those that have had the booster is a proportion. So, you know, you're getting decreasing coverage throughout, and we've as you know, we've tried a lot of different routes, different communication methods, COVID champions in communities, working with VCS organisations that are really close to their communities to try to increase uptake. So I think we'll just be doing a form of that for the foreseeable future. We will reach a point when the pop-ups are probably no longer the way to it, and there's quite a good coverage of community pharmacy provision now, so it might be around working with community groups to understand how we can support people to get to facilities that already exist. So the kind of three things that we look at are around convenience, which is why we've had the pop-ups, complacency, which I think is one of the biggest issues that we've got, and confidence, which is I guess the sort of vaccine skeptics. And what we've seen from the conversations we've had thus far, it's more around complacency than it is confidence. So I think we'll be working with those issues, with the sort of national picture changing depending upon the mood of the moment, really. So when the booster and the sort of lockdown over Christmas came, we saw really big demand for the pop-up clinics and across the other vaccine sites. And then when that messaging started to change a little bit, then that's when the demand has started to drop off. So we're kind of within quite a complex system of national messaging and local messaging, and trying to cut through is increasingly difficult as people construct their own reality based on social media and so on.
Okay, thank you. Councillor Story.
Thank you. Do we have anything on long COVID rates at all yet?
There's quite a bit of research on long COVID where initially, particularly in children, they didn't kind of have a control cohort looking at tiredness and some of the other effects. And I was reading something yesterday that was when you have a control group looking at things like tiredness, actually the rates of younger or children talking about being tired in the control group that haven't had COVID are just as high as it is in the group that have had COVID. So the thinking tends to be now that there is probably a sort of clinical issue with COVID that affects a very small number of people, and the long COVID stuff that we were really concerned about before around fatigue doesn't appear to be playing out in the numbers that there were before. Although I think it's probably one of those issues that's going to develop over time, and we'll become aware of the impact on other sort of chronic conditions like heart conditions and so on as a result of being infected. But it's still a little bit unclear. But I think in young people, less harmful than it appeared at one time. I think, I'm not saying it's not an issue, but it appears to impact a smaller proportion of people than it appeared at one point, where it looked like it was, 10%, 20% of children would be affected by something potentially quite significant. But I think the view on that's starting to change now.
What about in adults, please?
The most of the research seems to be in children and young people, but I'll see what there is in adults, and if there's anything specific, I'll get it through Scott to the group.
Craig, do you have something to say about that, or is it just another question?
It was just another question, Chair.
Okay, I'll call in. Are you happy with that, Councillor Story? Thank you. Councillor Cook, you have a question.
I'm always chuffed when I see Newport, and it's ever at the top. I honestly do not know how we can increase it at this point. I've attended and helped with most of the pop surgeries. I've went door to door. I think we've just exhausted it, and I think it's just a case of the national picture not helping, if I'm honest. Because when people are sort of saying that it's not real, and then people are seeing people act accordingly, it doesn't help, if I'm honest. And that's sort of what I've heard. My question is more around, with the hospital situation staying sort of level-ish, is it a case that people just aren't testing anymore?
No, because they'll all get tested in hospital, so that the hospital rates will be correct. It's quite difficult. What we used to do with the testing was look at the positivity rate. We can't do that now because most of the testing is lateral flow without the need for a confirmatory PCR. So we don't know what the negatives are. So we don't know what the proportion of positives are. But the hospital, the rates in hospital will be based on systematic testing. I think the issues with the hospital, people appear to be less ill in hospital with COVID at the moment, but it's still having an impact on the hospital, which is a very busy time, which Craig might be able to elaborate on a little bit. But obviously, the sort of winter pressures is a significant time for the hospital, plus standing up the elective activity that was lost through the previous waves of COVID are the bigger issues. And also people potentially cancelling elective surgery because of being infected with COVID. So there's a kind of, it's more that issue than necessarily the harm from COVID as a result of people being infected.
Okay, thank you.
Okay, Craig, do you want to come in at that point?
Yeah, cheers. Thanks, Chair. Just touching on what Mike said there and how busy the hospital is. Since the turn of the new year, South Tees have conducted around 3,300 operations, around 2,500 of which have been planned. So they are actually making good progress in terms of recovering some of the backlog that was caused through COVID. At the same time, they've been able to deliver around 70,000 outpatient appointments as well. So you can see that the hospital is incredibly busy, but continuing to deliver all of the services that we would expect it to. The reason I put my hand up earlier on, I was just wanting to pick up on whether or not Mike was aware of the impact of the antivirals that are being delivered from the COVID medicines delivery units in some of our trusts locally. Back in December, South Tees became one of the first hospitals in the region to support the delivery of antivirals to a cohort of patients that were that had specific comorbidities and were particularly vulnerable to COVID. And my understanding was that we've actually been able to support around 800 plus patients with the antivirals. But I was just wondering whether or not there was any feedback or evidence around the support that those patients had been offered, and whether or not it had supported them staying out of hospital and recovering sooner.
You've got more details on that than I have, Craig. I'm not aware of that. The only thing about antivirals that, in terms of the national picture, is it looks like it'll move more towards. I was at a national workshop last week, and with the need to isolate lapsing on the 24th of March at the latest, and therefore the impact on the testing and tracing and so on is likely to lapse as well. The question, or what they were looking to do, was how do we protect the vulnerable, and it moved from protecting the vulnerable through reducing contacts to protecting the vulnerable through testing regime targeted at the vulnerable, and then antivirals and treatment rather than stopping them getting infected in the first place. So there will be a shift based on the research that obviously James Cook have played a part in on antivirals. The issue that we had at the workshop last week was the definition of vulnerable was too narrow. It was just based on clinically extremely vulnerable, and clinically vulnerable didn't include unvaccinated, for example, as a vulnerable group. So I made those representations, and we'll see if that has any impact on the development of the national strategy. But no, I hadn't seen that stuff locally, Craig. No.
No problem, Mike. We'll pick up with the hospital and see if we can get a regular feed into you in terms of the uptake that we've had. Cheers.
Yeah, thank you.
Okay, thank you. I noticed on the television this morning you mentioned about the death rates, etc. They were trying to say that there was a large death rate, but they were saying the underlying COVID rate for deaths is much lower. It was, say, 300 in deaths. They're saying, well, it was only maybe 120, 140 were absolutely down to COVID. The other one is what you said, that you've died with COVID, not from COVID. Do you see that as a problem in ongoing, or is that just something we're going to have to live with?
I think the better measure is probably the excess deaths measure, actually, rather than those with COVID on the death certificate. But I think that'll probably continue on in the evaluation of impact and harm of COVID. I think the key thing that we're going to need to gear ourselves up in addition to all the stuff that we've talked about with the vaccine, is being clear about whatever the next variant's going to be and how quickly we're able to respond to that, as a lot of the existing stuff that we're reliant on gets stood down. I
see there is a new variant of the Omicron variant, but it doesn't appear to have got going yet. I hope it doesn't get going, but it's sort of like an ongoing thing. I suppose it's when we get winter out of the way into summer, it's allegedly not so bad, but then we got the autumn season, so it's a little bit depressing, I think. Craig, you have another question or comment?
Yeah, it was a comment really. Just in terms of the number of people in hospital with COVID, I think what we're finding now is there's a lot of incidental COVID, so people are being admitted for other conditions, and once they're tested in a hospital environment, they're actually testing positive, but it's not the COVID that's caused their admission. So I think that kind of signals where we're at the moment in terms of the evolution and the development of the pandemic, and the fact that it's something that's here now and it's in the background, and it will be for quite some time, and we've just got to try and get on and work with it and understand how we can best manage those patients who've still got a need to come into hospital for other treatments.
Okay, thank you. Any other questions on that? Kind of thank you for coming, Mark, and also you, Craig. You quite willing to stay, but there's not much more left on the agenda. Thank you.
Thank you.
And if you can send that update to all the members as well via Scott or whatever, or Caroline, that would be would be great. Thank you.
Will do. Thank you.
Okay. Next. Then there were 4. The next is sort of the update on OSB, which happened, which I've got here somewhere. All right. Just a minute. Someone's been trying to ring me. I can wait. The next bit's OSB. Unfortunately, I had to leave the meeting halfway through, but OSB was quite interesting. We had the executive forwards work program, followed by the chief exec's update, which again was very interesting. We then went through the scrutiny chairs update and things. And after that, the Adult Social Care and Services Scrutiny Panel final report was given. Then was the medium financial plan, the budget consideration consultation, which was a very important thing to do. So that's a very brief description of OSB at the last meeting. Okay, I think that's about where we are. I don't think there's anything else particularly on this meeting. There's no other business. Has anybody else got any questions or queries? No. So we shall look forward to the next meeting. And thank you very much for attending. We'll see you later. Thank you.